Hi everyone, I want to talk about anemia in children. Anemia in children. Let's briefly look at the different age groups and the possible causes of anemia in them. Not all the possible causes, but the main ones in different age groups, like neonates. Neonates are the wonderful human beings between day 1 and the first 28 days of life. Here we can have situations like autoimmune hemolytic anemia, infection, or genetic problem. To those between the ages of 3 to 6 months, maybe we're dealing with sickle cell disease, form of SS, SD, or SC, or we're dealing with thalassemia if the individual is from Mediterranean or Middle East. If this child is 6 months old and older, then we might be dealing with many causes that could be similar to the causes found in adults. And that may include malnutrition, bleeding from any parts of the body, lymphoma, leukemia, iron deficiency anemia, X-linked disorders like glucose-6-phosphate dehydrogenase disorder, and Sideroblastic anemia. The bleeding could be from bleeding dyscrasia of any sort. Clinical features will involve fatigue, just like in others, lightheadedness, that is, in older kids who could actually tell, weakness, tiredness and exertion, palpitations, dyspnea, dizziness, and syncope. But we can observe jaundice, color derived, melena, bloody stool, and the older kids could tell about tinnitus or not. Older kids will be able to tell if they're confused or neuropathy, fainting, and when you check the blood pressure, it's likely to drop. And on physical examination, you're likely going to pick splenomegaly, which might be secondary to hemolysis. The clinical features could also include hematemesis and epistasis, particularly if there is bleeding dyscrasia, and pallor picked by the parents, teachers, or neighbors, fever if there's associated ongoing infection, also with cough, and discharge. HIV is a possibility, and the type of medications that the child has been placed upon could give a clue. And sometimes, depending on the genetic constraints or race, we may be looking for the characteristics of sickle cell disease, particularly in the blood. Diagnosis of anemia in children could be made by knowing the value of hemoglobin, and if it is less than 130 grams per liter or 13 grams per dl, that is an anemia. And also going to check mean corpuscular volume. If it is increased, then we might be suspicious of disseminated intravascular coagulopathy, Hemoglobinopathies, Hemolytic anemia, Spherocytosis, Elliptocytosis. Is there any ongoing liver disease? What is happening to the thyroid in case of hypothyroidism? Splenectomy here, vitamin B12 deficiency, and folate deficiency. Still on diagnosis, checking our MCV, and the value is showing that it is low. So this is microcytic anemia, right? Okay, then what are the possible differentials here? Could it be thalassemia, iron deficiency, anemia of chronic disease? But how chronic could that be in a child? Depends. Sideroblastic anemia, gamma thalassemia, And if this is newborn, we might be thinking of twin transfusion, lead poisoning depending on where the child is living, zinc toxicity, copper deficiency, and abruptio placentae. We're still on diagnosis, and we're going to check the reticulocyte count. If it is low, then we might be dealing with prematurity here. And that will take us to know the gestational age for delivery, and we'll be able to ask about history of pregnancy. And this might be as a result of bone marrow suppression, particularly if there are medications being administered recently. But reticulocyte count is expected to increase if there's ongoing hemolysis, and we might be suspicious of possibility of resource incompatibility here, and that will take us to test the resource of the child and that of the mom, knowing that if the mom is resource negative and the child is resource positive, and this is not the first child, then we are going to ask whether in the previous pregnancy or pregnancies the mother had been given Rogan. And if that is not the case, then it's not surprising that now a child with resource positive to a mother with resource negative with previous resource positive pregnancies without Rogan could now be dealing with hemolysis right now. ABO incompatibility, the same process. Still on diagnosis. If there's hemolysis and we're not sure, we just need to check some parameters. We're going to check autoglobin, LDH, and reticulocytes. If there's hemolysis, it is expected that autoglobin will drop, LDH will rise, and of course reticulocytes will rise. But it's possible there's hemolysis and reticulocytes will still be down. In that case, there's pancytopenia with bone marrow suppression. Still on diagnosis, we want to know if there's problem with the liver. I'm going to check bilirubin level. And it might not even be a problem with the liver, it might be hemolysis. And in that wise, we're going to find unconjugated hyperbilirubinemia. Then we can assay for G6PD, hemoglobin electrophoresis, osmotic fragility, bone marrow aspiration to know what's going on there, lead level to know whether there's lead poisoning. We're going to review the medications that the mother has been taking, and of course blood culture to rule out any ongoing infection. Still on test, we're going to rule out the renal disease because when there is renal failure, there will be decreased erythropoietin production. And with decreased erythropoietin production, there won't be enough red blood cell formation, and that will lead to anemia. Thyroid function test because of hypothyroidism will be appropriate. Liver function test, just like I've stated earlier. Vitamin B12 assay in case of megaloblastic anemia. Diet in case of malnutrition. Particularly, we want to know whether this individual or this child is taking food that contain iron or iron fortified cereal. We want to know the level of iron and ferritin and total iron binding capacity to rule out or rule in iron deficiency anemia. We are going to look for possible causes, and to those who have followed this presentation from beginning so far, you yourself will have picked so many possible differential diagnoses. However, I'm going to talk about few major ones like glucose-6-phosphate dehydrogenase deficiency, pyruvate kinase deficiency, ongoing infection, hypothyroidism, Thalassemia, autoimmune hemolytic anemia, hemolytic uremic syndrome, or thrombotic thrombocytopenic purpura. And the history of this pregnancy will give us a clue if the mom had been dealing with either toxoplasmosis, rubella, cytomegalovirus, herpes, or there's anything that has caused disseminated intravascular coagulopathy. And of course, we're going to find out if there's any ongoing bleeding somewhere. Causes still continues if the peripheral smear is suggestive of upper segmented cells, then are we dealing with B12 deficiency, folate deficiency, or sickle cell disease? Spherocytosis or jelly bodies is pointing to post-splenectomy. Yes, I will briefly mention red blood cell distribution width here. The normal range is 11.5 to 14.5% and could be increased or decreased. And I'm not going to lay too much emphasis on it because it is less significant in determining red blood cell deformity. So I'm not laying too much emphasis on that, so just for academic purpose. If you do peripheral smear, you'll be able to come down on whether you are dealing with microcytosis or macrocytosis based on the value of MCV. If there is atypical lymphocytes, you might be dealing with infection. Basophilic stippling will be pointing to lead poisoning. Spherocytes in spherocytosis, fragmented cells in microangiopathic anemia. Target cells and sickle cells, of course, that is self-explanatory, is pointing to sickle cell disease. Actually, I'm going to make a separate presentation about sickle cell disease. Hence, bodies will be pointing to glucose-6-phosphate dehydrogenase deficiency, while jelly bodies will be pointing to possible post-splenectomy. In conclusion, it is never too much to do all tests until the specific diagnosis is made. Not for any reason, just because these are young individuals, young human beings. When we make the correct diagnosis about the possible problem they have right now, we might be able to assist them to grow to their full potential in life and probably guard against some issues that will lead to more anemia in future. I'll give a specific example here. If a child is being diagnosed with sickle cell disease or thalassemia or G6PD, particularly G6PD, not because it is the worst, but because if the individual avoids some medications like primaquine and some food items like fava beans, the possibility of hemolysis will be down. So if that type of determination is made, or this child is having hypothyroidism, and you are able to pick that and you help with exogenous tyrosine, in fact, not only that you're going to correct anemia, but the growth and other aspects of life of the affected child will improve. So it is nothing too much to do all possible investigations to come down to the specific diagnosis. And if you think your center cannot hold that, please make appropriate referral to the appropriate pediatricians. Thanks for listening to my presentation. Kindly subscribe so that you can get these presentations immediately they're published. Thank you.